Hi there, welcome to Antibiotic Therapy. This is for 212 Farm, although I wrote nursing on there, but it's 212 Farm. We're going to do some kind of refresher of antibiotics that you learned already in 112. We're going to review our objectives here in a minute, but we're going to discuss resistance and how to reduce and overcome resistance a little bit more in depth than we did before too. So identify some commonly used antibiotics, talk about their action, and the different classes have different actions, we know, and talk about the resistance to the antibiotics and nursing measures to reduce this resistance. Okay, so we're going to talk a little bit about required resistance being a battle between bacteria and pathogens, and some of the things about what we're going to do to prevent it. It's not a futile thing. There are some things we can do to try and combat it, do some teaching, and just know that we can have some effect on it. We know that all bacteria talk to each other, and once one learns that it can overcome being killed, it teaches others to do the same just by replication and making more of that kind of cell that's resistant. So we'll talk about this a little more in a minute here, but you can see that when you treat an infection, you kill most of the bacteria or the organisms, but even if there's just one resistant organism, then that one can remain and then divide and grow and make more and be infecting the person. And so now you get a whole bunch of resistance just from that one that was developed with resistance. So if you get sick here, this is where all the pathogens that we need wiped out aren't wiped out, and that's going to cause some of this resistance there. I have this video here. Let me see if I can get it to play. Sometimes this playback when we're doing recorded doesn't quite work the way we think it's going to work. Of course, this is how this is going to be for me. Just a minute here and I will get it going. Play back. Play. This is interesting about antibiotic resistance evolving.
So we ended up building with basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands. Base each band would normal petri dish pick agar at different amounts of antibiotic. On the outside, there's no antibiotic, just in from that. There's barely more than the people might survive. Inside of that, there's 10 times as much, 100 times, and then finally, the middle band is 1,000 times as much antibiotic. And then across the top of it, of course, the pin agar, that bacteria can move around in. The background is black, and the bacteria here is white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
All right, that was pretty cool. So I left this link in here if you're just printed it and you want to watch it again or what have you. Let's go on to how antibiotics work. This is kind of the mechanism of action of antimicrobials. You see with number 1, which is kind of down in the corner there, RNA synthesis inhibitors, including rifampin. It needs to get across into the cell, so it has to get through the cell wall to do its mess with the RNA synthesis. The protein synthesis inside the cell, again with number 2, there's protein synthesis inhibitors, the aminoglycosides and the macrolides are the couple that we're going to talk about for sure. And then number 3 is antimetabolites. They interfere with the function. Sulfa interferes with the function of folic acid, so the bacteria in this case figure out a different way to make folic acid. That's how they overcome and become resistant to sulfa. And then up on the top, the number 5 DNA synthesis inhibitors, the fluoroquinolones, they also need to be inside the cell to be active and to interfere with the DNA synthesis. The cell wall synthesis inhibitors, number 4, I guess we went out of order a little, but whatever. Number 4, the cell wall synthesis inhibitors, carbapenems we'll talk about, cephalosporins, isoniazid, penicillins, vancomycin. They all are cell wall synthesis inhibitors. So all of these have lost a lot of resistance already built up to them, and we're going to talk about that a little bit too. All right, so some mechanisms of resistance. We're going to talk about this with each drug as well in detail later, but there's destruction of the drug, which is the most common. The beta-lactamase is one way to do that, or the penicillinase. It inactivates the antibiotic, and it doesn't allow, the enzyme damages that lactame ring. Remember their beta-lactame ring that they have, and then the antibiotic is no longer effective in killing the bacterial pathogen because the drug is destroyed. So also preventing the drug entry into the cell. Some drugs need to get inside to affect the protein synthesis or the DNA synthesis. So if there is a system to pull antibiotics into the cell, this is where the microbe alters the system and it turns off the pump or changes the pump. It's called efflux pump in this picture up here. So it changes that ability so it keeps the antibiotic out. They can get, sometimes the removal of these resistant pumps, the antibiotic can get into the cell, but then the bacteria pumps it back out, or it uses the organelle or the ribosome in the bacteria to pump antibiotic out. So then it doesn't get a chance to interfere with protein synthesis. Also, it can alter the metabolic pathway or target site, resistance at the cell wall. So penicillin, we know, binds to penicillin binding protein on the cell wall, and the microbe that can alter this binding protein, so then penicillin doesn't attach to it any longer, and it can't damage the cell wall. Penicillin, we know, binds to... Oh yeah, I already read that part out. Okay, so what happens is it activates the cell wall action of that antibiotic, and this has some to do with MRSA resistance with penicillin. Let's see, alternate thing I got to tell you here. MRSA bacteria, they alter the penicillin binding proteins that have a low affinity for penicillin. So it's not that they're producing an enzyme or doing anything else, but they've altered these penicillin binding proteins, and that's what keeps the penicillin from working in that on the methods on the staph. Okay, so also another way is that the microbe alters the metabolic pathway. So sulfa, we know, interferes with the bacterial synthesis of folic acid. They need this to grow. They make their own folic acid, and sulfa interferes with that, and that's how it kills. But they can interfere with this formation. They figure out a different way to make their folic acid, so then there's a different drug that's going to be needed because they've figured a way around this folic acid production. So there's a good picture here. There's a good picture here that shows you this whole process and the different ways. If you can read through it a little bit, it tells about the enzymes produce inactivating antibiotics and getting rid of those links that it used to hook up to the protein, changing the proteins, different entry ports being changed, those pumps being changed, and then it shows in the middle how these cells acquire and pass on this resistance to other cells. And then down at the bottom it talks about increasing resistance. So it's just kind of a good overview as well. I went one too far. Preventing resistance. We want to try to prevent infections. There's three main ways we're going to do this. Prevent infections by vaccinations, like for pertussis. If you don't get vaccinated for that and then you treat them with penicillin each time, this increases the risk of resistance developing. So if we just give the vaccine, then you don't get sick and you don't need to have antibiotic given to you. The pneumococcal vaccine prevents infections and reduces the use of antibiotics and also reduces resistance this way. As nurses, we're going to provide aseptic care with all our procedures. So important things to remember is to remove all the lines that we can as soon as possible, like the ET tubes, IVs, central lines, Foley catheters, especially Foley catheters. We want to get them out soon so that the tube doesn't lead to infection. We know that there's increased likelihood of infection with this path right to the bladder. So getting rid of those lines and using our aseptic techniques, especially when we're putting any of those in. Then we want to diagnose and treat antibiotics properly. You want to draw the culture first before you give antibiotics, and then deliver antibiotics as soon as possible once that's done, once the CNS is done, and then see exactly which bug we're going to be treating, and we'll narrow it down and use that specific narrow spectrum antibiotic. Many times they're not going to use a culture to treat based on community resistance monitoring. So say the lab does 30 to 100 sputum samples over 30 days, and 80% of those are caused by one particular bacteria. And out of those, 90% of that bacteria is sensitive to one specific antibiotic. So the providers are aware of these community monitoring factors, or they should be, so that they would know that, oh, means we give antibiotic A because this is what the sputum is, and all these people have already shown that it's working right. So sometimes you might not see the culture and sensitivity done. But nurses aren't going to be doing that, but you should be aware of these community trends of when they don't draw cultures and when they will. The next step to keeping resistance down is to make sure that you finish the entire dose. Many times we feel better, so we want to quit taking the medications, but we need to be heavy on our teaching that even when you feel better, you got to keep taking it till it's all done, because you want to kill all the microbes that are there, even if you're feeling better, because that decreases resistance. Remember at the beginning where we had even just one microbe that was resistant, and then it didn't get killed, and it went on to make more resistant microbes. So the final thing is using antimicrobials correctly. We know that antibiotics are not for viruses. You can be hospitalized for a really bad viral infection, and they're going to treat you symptomatically. They'll give you rest, they'll give you fluids. Same thing at home. They don't give you an antibiotic if you go to the doctor and you just have a viral illness. You go home, you rest, you have fluids. We know that antibiotics will not help, and it increases the chance for resistance from doing that. This link at the bottom, it shows how resistance has been improved by use of the pneumococcal vaccine. It's a pretty short one. You're welcome to look at it. It's not specifically on the test, but it's just good to be aware of these things. All right, and then prophylactic antibiotics. This isn't something that you think of doing that often, but it does happen in situations that are at such high risk for infection already. One is this deep wound, any kind of deep wounds, like a dog bite or a cat bite, where the bite or the wounding pushes bacteria deep into the tissues. It's hard to irrigate or clean it out. So even in the absence of infection, you might get an antibiotic to keep this infection from occurring in these deep wound tissues, deep tissue wounds. Contaminated wounds are similar. Like if you have these wounds and you're out and it's full of dirt, there's a lot more bacteria, high likeliness that you're going to be infected. So that person might get antibiotics as well. Also, You see they sutured a couple of those and they left some other ones open on that leg or whatever tissue it is we're looking at there. They might be leaving wounds open so that you have a chance to get the infected material out and let the contamination come out or the pus come out and be cleaned, so that when you do give antibiotics, they will be able to treat the microbes and not have to fight through all that pus. Preoperatively, in general, there's this I think it's called SCIP, where those are an acronym for something to prevent surgical site infections, but they decrease your risk of post-op infection. Sometimes they use cephalexin, sometimes Vanco, especially for dirty surgeries, like anything, puncture, abdominal surgeries that have a lot of bacteria load in them as well, because of the kind of surgery they are. STD, sexually transmitted disease exposure. We know that if the partner has chlamydia, for example, if one person gets chlamydia, the partner is going to need to be treated even if they don't have any symptoms, because they've already probably passed this bacteria back and forth. If they have HIV, they're going to get antiretroviral therapy or antiviral therapy. And then if we get exposure, there's, therapy for the person who's exposed, especially if the person's HIV positive with the exposure, because you don't want seroconversion, which is converting to being HIV positive. So providing antiretroviral drugs right away can help people stay seronegative. They won't be converted to having antibodies to HIV virus. We know that antibiotics aren't good, but the antiretrovirals and antivirals are what we work on with that. Right. So we're going to talk about the first antibiotic is cell wall antibiotics. We have you learned about this in 112, the beta-lactams, penicillin, carbapenems we're adding. You didn't hear about them too much before, and cephalosporins, vancomycin. The beta-lactam ring makes them very effective, and then Vanco works in several ways, including the cell wall. It attaches to the cell wall to weaken the connections, and then the cell wall breaks down, and then the cell has that higher osmotic pressure and it releases its contents out and dies. So there's this beta-lactam ring structure in the picture there. It's showing the different kinds of beta-lactam rings that the different antibiotics have. And then let me see if I click, if this goes forward with the click. I thought I had another picture in here. Okay, I do have another picture in here, but it won't let me click through it for some reason. I don't know what the heck is going on here. Well, anyway, after this one, there's this picture, which you've seen before. This is the picture showing how the cell wall has the strong cross links with the transpeptidase making it strong and linked, and high osmotic pressure inside the cell. And then the antibiotic inhibits this transpeptase and breaks these cross links, and so then the cell lyses due to its weakened wall and this high pressure. And then I'm going to put this picture back over the top again, so it'll scooch back over. Okay. So now we're going to go on to the penicillins. Penicillins, we got penicillin G, amoxicillin, ampicillin. There's a lot of penicillin resistance now, though. So we have other drugs, nafcillin, oxacillin, dicloxacillin. The beta-lactamase is the enzyme that is makes the microbes that makes the penicillin not work. Penicillinase resistance is specific for penicillin. It's not sensitive to beta-lactamase, but it's still going to be effective to get through the enzyme. We use a beta-lactamase inhibitor. With ampicillin, amoxicillin, we add sulbactam or clavulanic acid. And this actually might be the wrong slide, but either way, let me just keep going here because we're talking about penicillin resistance. We have this beta-lactamase inhibitor, clavulanic acid, and then the antibiotic inactivates the beta-lactamase, so then more of the drug, like more ampicillin, can get into the cell wall and hook onto the cell wall. And this goes back and forth with antibiotic development. We see it commonly from a hospital standpoint. You might see Zosyn and Unison. The adverse effects with the combos are due to the antibiotic itself. The clavulanic acid or sublactam is not a bactericidal agent, and so no adverse effects are going to be from that. They're just going to be from the penicillin. And then the beta-lactamase inhibitors are not effective against penicillin binding proteins. So this picture here I put in because it shows your beta-lactam ring, and then it shows how the beta-lactamase, which is that enzyme, breaks the bond in the ring, so then that makes the it makes the penicillin into a different molecule, and it's not functioning anymore against the bacteria. So then it makes the bacteria resistant to penicillin. Okay, and then this little YouTube is a short one again that shows the how MRSA has been gaining across the nation over time. It's not a very long one either. It's not on the test. It's just for your information. If you want to watch it there, you can copy and paste that in and go watch that. Okay, so we want to, let's see, I think on this penicillin one, we know that penicillins are common, and that the side effects, diarrhea, rash, and we know about the cross allergy, but you got to ask the patient if they are really allergic to what kind of reactions they had when they were allergic to either the penicillin or the cephalosporin, to know, is this cross allergy real, or is it just the really small 10% that it's not a really common thing to have this cross allergy. So really the important point to take away is it's only about 10% of the people have this cross allergy, and usually if they report they had trouble breathing or that it was more like an anaphylactic reaction, then yes, it's a contraindication. You're not going to get the cephalosporin if they were saying they had the anaphylaxis with penicillin, or vice versa. Anaphylaxis with cephalosporin, they're not going to get penicillin. But it is a very small 10%, so it's not an absolute contraindication that if somebody's allergic to penicillin, they cannot have cephalosporin. You have to ask about what kind of allergy they have. So they can get cephalosporin if they're allergic to penicillin. We just got to find out, was it just an itchy rash or just a GI and the rash, not anaphylaxis. Okay, so when we're talking about resistance, the penicillin binding proteins in the cell wall, that's where penicillin latches on and damages the cell wall. And then I talked to you about this picture already where the bacteria change the penicillin binding protein shape so that the penicillin can't bind to it anymore. MRSA, or methicillin resistance, is this type of has this type of problem. And what do we do with MRSA? When penicillin isn't effective, they shift either to Vanco or other 4th or 5th generation cephalosporins that have less resistance problems. That's one way. The other way, sorry about that. The other way is to, let's see, I lost my spot. Different drugs that may be used. Okay, one way that changes the shape of the penicillin binding protein. That's one way resistance happens. The other way resistance happens is that this beta-lactamase enzyme also inactivates. So you have the antibiotic can't work anymore against the cell wall. So you have to find different drugs that'll work on those kinds of resistances. Okay. There we talked about all of those. So adding the beta-lactamase inhibitor, which is the sulbactam, like the drug Unison here, clavulanic acid, augmentin, more clavulanic acid. So these things have the beta-lactamase inhibitor, and it's a combo drug to help this penicillin type medication still get in there and attach to the cell wall and do its thing with breaking the cell wall down and binding to these proteins, to the proteins they need to. Well, let's go on, because I talked about all these already and you have them in your slide there, but then we go on to cephalosporins. So this one, there's lots of generations. They're not the big guns. The first generation, gentamicin, as we go to higher generations, the antibiotics have less resistance. Fifth generation, they really developed it to try and work against MRSA. It's effective against resistance and it's stronger. Ceftriaxone can be IM, a one-time dose for every 24 hours. So you can get that one as an outpatient, and if your infection's not getting better than a second shot in 24 hours, the teaching on that one is that it burns a lot and it's long-acting. So why am I only getting a one-time dose and it's going to hurt a lot? So 2 teaching points there. Rocephin is the first cephalosporin to make it into the CNS, so that you can fight infections within the brain like meningitis or other CNS infections. And then just because I skipped a couple of slides in order here, when we were talking about these mixes of drugs and the way to combat resistance, we know that this clavulanic acid is going to allow more of the amoxicillin to get in and reach the pathogens. And I just wanted to make that point real clear with you guys. And then we're ready to go down to the carbapenems, which is imipenem, celastin, or Premaxin. The carbapenems are still the beta-lactam type of antibiotic based, but their ring is different than penicillin and cephalosporins. The imipenem celastin combo, the imipenem, I can't even say it now. Imipenem is the antibiotic part, and all the ones in this group are penems of some sort, but it's used for mixed infections, aerobic and anaerobic, gram-negative and gram-positive, and some MRSA that are not susceptible to beta-lactamase are still effective against some of the MRSA strains there. It's powerful. It's used for serious infections. And then you see the celastin. The celastin part of it is not, it's not a beta-lactamase inhibitor, but what it does is it protects the imipenem against destruction from renal enzymes. And you see in this picture, the renal enzyme is this dehydropeptidase. And what it's doing is, see, it's breaking down the imipenem and not allowing it to get carried into the cell or to do its job. And so when you give celastin, you're allowing the drug to get in. Also, when I was looking up information about this celastin, you see this nephrotoxic drugs. They also use celastin to combat some of the nephrotoxicity of other kinds of drugs that they give. So that was an important thing to hear about, that celastin is used in other ways than just being combined in here with like this Premaxin. Let's see if I finished everything on that. Okay, we're ready to go on to vancomycin or vancomycin. It works on the cell wall. It also interferes with RNA synthesis and the plasma membrane of bacteria. So 3 mechanisms makes it difficult for bacteria to develop resistance again to this vancomycin. It's very effective for serious infections and resistant organisms like MRSA because of this multiple mechanisms of action. The drug is still effective, but it means that you should be thinking it's reserved only for these people with serious infections and for MRSA, and not to use it for regular or less severe infections. So that's kind of a sticking point. Sometimes you see vancomycin used, and it probably should not be used because it's really should be saved for this serious issues. If it's given IV, and if you're really sick, getting it at home, you might have a port or a PICC line. It's pretty hard on veins. It's not absorbed well from the GI tract. So with that being said, when somebody has pseudomembranous colitis and with C. diff, The oral form is effective when it's given this way because it acts locally in the gut to help with killing, helping you clear your C. diff. So it acts locally. Also, Flagyl is good for C. diff. But orally, if you see Vanco given orally for somebody with C. diff, that's the reason they're giving it that way. Even though it's not absorbed well, it's going to work locally. Red man syndrome from histamine release is a problem that you might see. They get a flushing vasodilation, hypotension, they get tachycardia, and there's ways to prevent this. Give it real slow, at least over an hour, and also will decrease the problem with vein irritation. It's ototoxic, nephrotoxic. The patient might already really be sick, and so they already have some increased risk for acute kidney injury. With the two things we're going to do for sure is monitor their creatinine and their BUN to check on their kidneys and see how hard we're being on them. But we want to treat them, so you just have to watch out that they're getting treated properly. Okay, we're going to take a little break and then go on and do other antibiotics after this.